Just wanted to take a few minutes and share a few slides about a process that UNICEF and a number of partners have been engaging in East and Southern Africa called All In, which is really trying to understand the situation of adolescents and HIV in the region. Really a simplified process of prioritizing populations, locations, and interventions, and looking at what that means for our decision making. And it's not sort of hardcore research methodology or surveys, but really a practical guide to conduct comprehensive assessments to lead to a focus on adolescents and HIV, to bring them to the center and to be part of our response, and to really look at those who are at greatest risk of infection, illness, and death. So why did we embark on All In? It's a slide showing estimated number of new infections among 0 to 14, 15 to 19, and 20 to 24-year-olds in our region in the last 15 years. And you can see the blue line, the decline in terms of new infections among 0 to 14-year-olds, and really speaks to the progress we've made in PMTCT, where we've had thousands and hundreds of thousands of new infections averted. But what really struck us when we started to look at the data about 18 months ago with colleagues from WHO and UNAIDS was that we're not seeing that same decline among 15 to 19-year-olds and 20 to 24. And in fact, in all age groups, we're seeing progress and things are improving, except for in this among older adolescents and young people. Of course, we also know. Sorry, it's not. Don't know what happened to that the graph there in the translation, but it's very simple. The blue part of the pie is really the burden of HIV in this region. As Pierre said, we're not going to make progress globally unless we make progress in this region. This is the region that carries the burden of new infections among 15 to 19-year-olds, and it's also the place 58% of AIDS-related deaths globally among 10 to 19-year-olds are in East and Southern Africa. And of course, adolescent girls and young women, where in sub-Saharan Africa, 7 in 10 new infections among 15 to 19-year-olds are among girls. There is, I think, hopefully part of our discussion in the next couple of days, I think some interesting data around what is happening to adolescent boys as well, and looking, making sure that our gender analysis includes boys as well as girls, but obviously for many, many, many years, the disproportionate impact of HIV on women and girls is a pressing issue that we just haven't done enough about. And then, of course, as part of the landscape in the situation is that the majority of adolescents just don't know their HIV status, that we have huge gaps, not only in access to services, but even 25, 30 years into the epidemic, in very high burden HIV countries, we still have glaring gaps in knowledge. So in February 2015, the All In agenda or All In initiative was launched in Kenya by President Kenyatta, and it's a multi-partner initiative, really, with governments at the center when we work in countries, and strong collaboration with private sector, UN family, as well as bilateral organizations and agencies, as well as civil society, adolescents, and young people. The goal is a broad one. It's about ending AIDS among adolescents by 2030. And All In is really a platform to raise the issue and to catalyze action and influence policy, and to accelerate results for adolescents. It's an opportunity to complement the existing initiatives, which I'll just touch on in a minute, and as well to start to shine a light on the issue so that we can also look at our investments and resource mobilization. It's an opportunity to look at the data and improve the collection and analysis, but really the utilization, and I think that's where the evidence base comes in. If we have the data, and even if we have gaps in data, what are we going to do about filling those gaps, but using the data that are available? And as well, a really important principle of All In has been the meaningful involvement of adolescents and young people. I think often we give a nod and we talk about engagement of adolescents, but it often ends up being tokenistic, even if we try to make it meaningful. And so, really looking at different kinds of ways and approaches where they really truly can be engaged, and not just come in at the meeting at the very end and make a comment. As I say, it's really it's a framework. It's not a new initiative where we come in, everything else stops, and this is what we do for the next 6 months, and then something new comes. But really, an effort to bring together a number of existing efforts. Of course, the 90-90-90, PEPFAR Dreams, as well as the PEPFAR Act, have been two critical initiatives in our region, in East and Southern Africa. As Pierre mentioned, the Linkages initiative work with a number of initiatives with civil society organizations doing work on HIV/AIDS specifically, but also on issues like preventing violence and a broad range of areas that affect adolescents. Broadly, what All In has been, it's been a way to assess the situation, take a snapshot of the landscape. What we did was develop a very simple tool, an Excel spreadsheet, to help identify the gaps, look at issues of equity, and look at some of the low-performing areas and services, to analyze the bottlenecks that exist as barriers to being able to access services, and then to define course correction. It's been a three-phase process. Building on data that exists. Often there aren't data, so that's something that we can discuss further, to try to build a profile of adolescent health and well-being. The well-being part is very important. It's not just about health indicators, but looking at multi-sectoral indicators in areas that affect the lives of adolescents, and really looking at the context, looking at the data, reviewing the data, and having a validation process. It won't surprise you that government really has to be at the center of all of this and should be at the center, bringing partners together, but making sure that there's a process of validating that data. The next phase, which we're engaging in a number of countries, is putting together subnational teams in applying a bottleneck analysis and really digging deeper in terms of why services aren't meeting the needs of adolescents, and looking at, very basically demand, supply, and enabling environment, and how all of those elements can come together. And then lastly, it's really just about the planning process and decision-making process and course correction, where the programming is not meeting the needs of adolescents. Where we are in the region is that we've conducted rapid assessments in 10 countries. This process has happened globally in 25 countries. In East and Southern Africa, it's been most accelerated in 10 countries. And we've started the phase 2, the subnational in-depth data analysis in a handful of countries. Interestingly, in Kenya, because of the county system and because of how they approach the issue, they decided to bring together phase 1 and phase 2. So, one thing we've learned very quickly is that the tool is not fixed and there's no one size fits all, but really what they did was select high burden counties or districts in the country and then do the data analysis at district level, and then also start to look at the barriers and the bottlenecks at the same time. In Namibia, they're combining phase 2 and phase 3. So once you start to look at the problems and the barriers, what are we going to do about it? And talk very quickly about what some of that course correction might be. We've had, this is an example in phase 1, along with looking at the data. Part of the discussion is really about looking at priority interventions. So when you see this list, it's not terribly surprising. We know that these are the HIV interventions that should be prioritized. But what's been interesting is to have them listed in a validation meeting with decision makers in reference to adolescents. So, we don't often have that conversation about that age group in particular and these interventions. And the second is that looking at some of the interventions. So a number of countries mentioned VMMC, voluntary medical male circumcision, but only in terms of applying it to specific districts where they felt that there was a higher need or some sort of ability to move the issue forward. I think the other interesting thing is around this, issue of a multi-sectoral response. So in Zimbabwe, we saw the issue of case management approaches, community system strengthening, cash transfers where there's a national cash transfer program being prioritized as a way of looking at prevention, treatment, and care response for adolescents. And in Namibia and in Botswana, the issue of alcohol and substance abuse featured quite prominently, which didn't necessarily in other countries. Some of the key outcomes has really been that, along with drawing attention to the issue of adolescence and HIV, it's really put the issue of age desegregation and the importance of disaggregated data on the agenda. So in Kenya, the National Bureau of Statistics are now including age desegregated data for all of their counties, as they've learned from the process that's happened in 6 counties through All In. In Mozambique, they've added an adolescent component to operationalize it in their NSP, and a number of discussions with funders and donors. We obviously have the PEPFAR Dreams program, but this has also resulted in conversations with the Global Fund, reprogramming of funding in Swaziland, and now discussions in Namibia. I'm getting to the end, but the 2 most important slides is really some of the reflections of what we've learned in this process, which is a very live, active process. So this slide is really just about some of the data issues. Won't surprise anyone in this room to hear that most of our surveys that we have in country don't include 10 to 14-year-olds, and that we have there's lots of gaps in the data. And one of the main findings of the validation exercise is that we don't have a lot of data, but that alone has led to a discussion of what to do about it. This is also true at subnational level, just limited disaggregation. We also have very little data beyond the core kind of health service indicators. So issues, more broadly in health, like mental health or substance abuse, alcohol abuse, but also, not wide national surveys on broader social issues and social indicators. We also found in a number of countries confounding data. So you would see high condom use, but then incidence isn't declining. So what's actually going on? What are we reporting? What are we seeing? How old is the data that we're talking about? And I think one of the most important lessons is that to make sure, we've really been able to mobilize and work with our government counterparts around the issue of adolescence and HIV, but really to make sure that this isn't seen as an end in itself, that this whole validation exercise, bringing people together, looking at the data, is a means to do something. It's really easy to finish a process and have a nice dashboard and say, okay, we'll just keep updating the dashboard every month or every 6 months, but that's not enough. We have to do something with that information. And then some broader reflections. Of course, we need country and government partners at the center, and that their participation is critical. We need to strengthen the engagement of adolescents. There's lots of lessons from a number of countries, but one of the common themes is that it's very difficult to find a meaningful way to engage younger adolescents. They're often in school, so pulling them out for meetings is challenging, or if they're not in school, it's difficult to identify them and find them. I've been in sessions where we have a room full of young people and adolescents, and you say, how many of you are under the age of 18, and 3 people out of 50 put up their hands, and the majority, end up being young, into their 20s, which is terrific, which is fantastic. They have a lot to say, but really actively engaging younger adolescents is also very important, and finding ways to make sure it's meaningful and not to be tokenistic about it, and not a once-off, not just about coming to a meeting, but engaging with the data, looking at the data, making sure that it speaks to them in a way that's relevant, using technology to get information out, all sorts of ways to sort of innovate to work with, not just for adolescents. We also found a number of contradictory legal and policy provisions on consent in particular. So age of consent in many countries, age of consent to sex, to marriage, to getting an HIV test are all different ages. Generally, we have weak coordination mechanisms around adolescents broadly. Their lives aren't just about what you get at a health clinic. So they have multiple delivery platforms, but not necessarily a coordination mechanism in government to bring them together. So we also found challenges in engaging multi-sectorally. So it was relatively easy to get the Ministry of Health to engage, to get the Sexual Reproductive Health and the AIDS desk to come to a discussion around validation. how do you get to Department of Justice, Department of Social Policy, or Finance? That was more challenging. And then the last thing was really about, when we identified the problems, what really is going to be the process and the planning to act on them. So lastly, just to say that one of the I think one of the most promising or positive things that's come out of this process is, along with bringing attention to the issue, is really to look at working with our governments to leverage prioritizing age disaggregation and looking at the issue of adolescence and HIV, looking at some of the policy impact issues, resource mobilization. If we identify problems and don't invest the funds, we're not going to get anywhere. But also marrying that with the political engagement and the political impact. We can go deeper into some of the issues that came out, but I'll stop there and look forward to discussing further.